My name is Yannick Stemmler and I am a resident physician at University Hospital of Cologne in the group of Professor Oliver Corneli and as a physician in the Department of Internal Medicine, Hematology, Oncology and Infectious Diseases. And today I would like to present to you how we rule out COVID-19 disease in our patients admitted to our specialized COVID-19 wards and how to transfer them back to the regular wards. This presentation is on behalf of our attending physicians Jan Rübnicker, Norma Jung and Henning Grüll from the Department of Infectious Diseases and the Institute for Virology. So we prepared a flow diagram including two patient groups. On the left side you see patients who present to the emergency department or who get admitted with symptoms of an upper respiratory tract infection. And on the right side you see a flow diagram for patients with symptoms of lower respiratory infection. I'd like to start now with the left side. That means patients with lower respiratory symptoms such as cough or sore throat, reddened throat, body pain and fever, anosmia or loss of taste, and also headaches. If one of these symptoms is present, we perform a swab from the throat of the patients and examine it via PCR on SARS-CoV-2. And we do this twice. So we take two throat swabs. It is very important to pay attention to the technically correct way to obtain these swabs to improve the sensitivity of this test. And if these two tests result negative, we might transfer our patient back to a regular ward of the respective specialty. But if the attending physician still has doubts to rule out COVID-19 in this patient, so if the patient is persistently febrile or symptomatic or there are other suspicious signs of COVID-19 disease, one might consider to perform a low-dose CT of the lungs, which has a comparably high sensitivity also in early stages of the disease. And that's where the pathway on the left side ends. I'd like to present to you now the right side of this flow diagram where we have the patient population presenting with symptoms of a lower respiratory tract infection, such as dyspnea or also fever and productive cough, or also abnormal findings on physical examination, such as abnormal findings on pulmonary auscultation. So in these patients, we already include a low-dose chest CT in our initial diagnostic workup. And if we find no infiltration at all on this low-dose CT, we result at the same part which I explained a few minutes ago on the left side of this flow diagram, and only perform throat swabs on SARS-CoV-2, which we send to virology for PCR, and then continue as described. If we do have any findings on the initial chest CT, such as lobar infiltration or ground glass opacities, we have to rule out COVID-19 disease further. And for this purpose, we perform throat swabs on SARS-CoV-2 as we did before and examine them via PCR at the virology department. And additionally, in the case a patient is already intubated due to respiratory failure, it is possible to obtain tracheal secretion and also perform PCR. So if this throat swab results negative, we try to obtain additional samples such as induced sputum or perform bronchoalveolar lavage and obtain samples from there and also perform PCR on SARS-CoV-2. And if both exams, so the throat swab and the additional sample, result negative, we are able to decide that our patient can be transferred back to a normal ward where COVID-19 does not have to be ruled out. So now we are still in the patient population with lower respiratory tract infection and suspicious findings on chest CT. And we have already performed a throat swab on SARS-CoV-2. And this swab results negative, but how do we rule out furthermore? So if it's not possible to obtain any additional samples, which I already mentioned, such as induced sputum or perform BAL, it is also possible to send a serum sample, so a blood sample, to the virology department, where this can be examined with an ELISA antibody test specifically for SARS-CoV-2 to detect antibodies of the IgG and IgA type for this disease. It is important to note that this antibody test can only result positive when these antibodies have already been built by the immune system of the host, which can last 10 to 14 days after disease onset. Additionally, I'd like to mention that this test can result false negative in immunosuppressed patients. So we now have the situation that we obtained a throat swab and additionally a serum sample for antibody testing of our patient. If both of these tests result negative, we're able to say that we have ruled out COVID-19 disease in our patient and can transfer him or her back to the respective ward of the specialty. If, however, one of these tests, and especially the antibody ELISA test from the serum sample, result positive, we'd like to keep our patient on the COVID-19 ward, which is specialized on treatment for these patients, and do further diagnostic workup and clinical treatment. So in summary, here you have again the flow diagram to rule out COVID-19 disease in hospitalized patients who are already admitted on a specialized COVID-19 ward to rule out this diagnosis. It is very important to mention that this does not contain any treatment or any further diagnostic workup for COVID patients, only to rule out the disease. Thank you very much for watching. You find additional information and of course this flow diagram in the information box below this video. Thank you and see you next time.